and today we will try to learn how to diagnose a case of asthma coming to us in the OPD or in some cases IPD also. So, we all know that in the normal lungs, these are our normal lungs, the airway are wide open and we can breathe very easy, but what happens in asthmatic lungs, there is the airway hyperresponsiveness, bronchoconstriction, there is a mucosal edema, all leads to your narrowing of the airway that makes us difficult to breathe in and out. All right. So, this is what happens, and some of the distal part we can see here, there is air trapping also. This is all about your pathophysiology. We are not going to detail in the pathophysiology today. We will just have some points. We will focus our discussion for today to how to diagnose a asthma case coming to us in OPD. All right. So, what is the objective for discussion today? Today we will understand a little bit of definition of asthma and how to diagnose in a clinical practice, how to do a workup and how to diagnose and take home message at the end of the discussion. So, coming to the definition of asthma, this is taken from the GINA 2023, that we know that asthma is a heterogeneous disease usually characterized by a chronic airway inflammation. हमें मालूम है कि asthma क्या होता है, it's a very heterogeneous disease, have a multiple phenotypes and इसमें क्या होता है, there is a predominantly or basically there is a chronic airway inflammation that leads to mucosal narrowing and the airway edema that we have just seen on the previous slide. And it is defined by the history of respiratory symptoms like wheezing, shortness of breath, chest tightness and cough that vary over time and in intensity together with variable expiratory airflow limitation. So, each and every word of this definition is very, very important. So, what does it mean? It is defined by the history of respiratory symptoms. There is a history, there will be a definite history of respiratory symptoms like wheezing. When they will cough, they say that खांसते हुए और सांस लेते हुए मेरे को कई बार सीटियाँ सुनाई देती हैं. So, they like इस तरह से वो पेशेंट प्रेजेंट करते हैं and they describe their symptoms in this way. And there is a shortness of breath. Shortness of breath is obvious in the asthma because of the airway narrowing, airway edema and chest tightness. उन्हें क्या लगता है कि पेशेंट से दैट हमारी जो छाती है एकदम जकड़ी सी रहती है और बहुत भारीपन महसूस होता है समटाइम्स. सो एंड कॉफ, ड्राई कॉफ इज मेनली इन एस्थमा, इट्स अ ड्राई कॉफ, यू नो, ओके, विद अ वेरी मिनिमल एक्सपेक्टोरेशन एंड दैट में वेरी ओवर टाइम इन इंटेंसिटी. दैट में वेरी ओवर टाइम इन इंटेंसिटी वॉज इट मीन कि ये समय के साथ घट सकता है, बढ़ सकता है और पेशेंट के सिम्टम्स कम हो सकते हैं. कई बार पेशेंट बिल्कुल भी एसिम्प्टोमेटिक होते हैं. इसकी इंटेंसिटी भी कई बार कभी ज़्यादा हो सकती है, कभी कम हो सकती है. सीजनल वेरिएशन देखने को मिलता है. साल के कुछ महीनों में बिल्कुल ही अच्छे रहते हैं पेशेंट, कोई सिम्टम्स नहीं आते हैं, बट सम टाइम कुछ समय में कुछ सिम्टम्स में कुछ पर्टिकुलर जो सीजनल वेरिएशन होता है, कई बार कुछ महीने में उनके सिम्टम्स बढ़ जाते हैं. सो दैट इज that says that there is this very over time and in the intensity together with variable airflow limitation. इसको हम क्या करते हैं, expiratory airflow limitation को that we do by your doing PFT. जो हम PFT और spirometry कराते हैं पेशेंट का, उसमें हम इसको देखते हैं. Variable expiratory airflow limitation is characterized by your decreased FEV1 by FV ratio, that is a characteristic seen in case of obstructive airway disease. All right. So, coming here to asthma symptoms again to revise, it is a chest tightness. पेशेंट से कि मुझे सांस फूलती है, सांस लेने में बार बार तेज सांस लेना पड़ता है और जल्दी थकान लग जाती है, कई बार वीजिंग या सीटियाँ भी बजती हैं और ड्राई कॉफ रहता है पेशेंट को. ऑलराइट. सो दिस इज ऑल अबाउट योर डेफिनेशन ऑफ एस्थमा. एंड एस्थमा इज अ डिजीज, इट कैन pediatric, adult, geriatric also. It is almost, there is a no ages left for asthma. Asthma can happen in the early age, middle age or the late age also. All right. And how to make the initial diagnosis? वी ऑल नो, जैसे हम हर डिजीज के साथ डायग्नोस बनाते हैं, सबसे पहले हमारा स्टार्ट होता है डायग्नोसिस फ्रॉम हिस्ट्री एंड प्रेजेंटेशन कि पेशेंट की हिस्ट्री क्या है, क्लिनिकल प्रेजेंटेशन क्या है. दैट इज़ वेरी वेरी इंपॉर्टेंट. अ मेटिकुलस हिस्ट्री टेकिंग जो हम लोग लेते हैं पेशेंट की, हमारा मैक्सिमम वर्कअप, मैक्सिमम काम उसी से हो सकता है इफ़ वी हैव अ हैबिट फॉर टेक अ मेटिकुलस हिस्ट्री टेकिंग. सो हाउ टू टेक हिस्ट्री टेकिंग, उसका भी एक वीडियो है, आप इधर आई बटन में जाके देख सकते हो या नीचे लिंक डिस्क्रिप्शन बॉक्स में मिल जाएगा, आप वहाँ भी जाके देख सकते हैं कि हाउ टू टेक अ प्रॉपर एंड अ गुड हिस्ट्री. सो यदि आप अच्छी हिस्ट्री ले सकते हैं तो यू कैन हैव अ वेरी गुड आइडिया ऑफ व्हाट द पेशेंट इज सफरिंग फ्रॉम, व्हाट इज द एक्चुअल डायग्नोसिस. ओके. एंड देन यू विल do a clinical examination here. You can do investigation, that is necessary investigation, that is a basic blood work, and you can do a chest x-ray, and by the to diagnose a airflow limitation you have to do a pulmonary function test. All right. So, what is the history? Just we have seen that there is a characteristic pattern of respiratory symptoms such as wheezing, shortness of breath, dyspnea, chest tightness and cough, that will be there in the patient of with a bronchial asthma. So, here are the again to revise the symptoms of asthma, that are chest tightness, shortness of breath, rapid breathing, tiredness, cough and wheezing. So, these are all the symptoms of your bronchial asthma the patient present to us in our OPD. Fine. This is very important to know that patterns of respiratory symptoms that are characteristic of asthma. Asthma की ये जो pattern होते हैं ये classical and characteristic of asthma के होते हैं, and that are these typical symptoms are, they are very typical of asthma. These are typical respiratory symptoms of wheezing, shortness of breath, cough and or chest tightness that patient or especially adult experience more than one of these symptoms. यदि patient को पिछले समय में या उनको कभी भी इस तरह के सिम्टम यदि एक से ज़्यादा बार आए हुए हैं तो दे आर वेरी कैरेक्टरिस्टिक एंड वेरी क्लासिकली सीन इन एस्थमा. एंड नंबर 2 इज सिम्टम्स आर ऑफन वर्स एट नाइट और अर्ली इन द मॉर्निंग. यदि रात में उनको ज़्यादा दिक्कत होती है या बोलते हैं कि जब हम सोकर उठते हैं तो सुबह में बहुत ज़्यादा दिक्कत होती है, सांस फूलती है. सो इफ दिस सिम्टम्स लाइक चेस्ट टाइटनेस, वीजिंग, शॉर्टनेस ऑफ ब्रेथ, कॉफ इज मोर इन द अर्ली मॉर्निंग और इन द नाइट, दैट सजेस्ट एस्थमा. ऑलराइट. एंड सिम्टम्स में वेरी ओवर टाइम एंड इंटेंसिटी. जो सिम्टम है उनका जो समय के साथ वेरी करता है और इंटेंसिटी भी कई बार बहुत ज़्यादा हो जाती है, कई बार कम हो जाती है, कई बार बिल्कुल ही एसिम्टोमेटिक होते हैं, कोई दिक्कत नहीं होती है ऐसे पेशेंट को. एंड सिम्टम्स आर ट्रिगर्ड बाय वायरल इन्फेक्शन, एक्सरसाइज, एलर्जन एक्सपोजर, चेंज इन वेदर, लॉफ्टर एंड इरिटेंट्स सच एज कार एग्जॉस्ट, फ्यूम्स, स्मोक एंड स्ट्रॉन्ग स्मेल. सो एक्चुअली इनको क्या बोलते हैं, वी ऑल नो दैट दीज आर द एस्थमा ट्रिगर्स. सो इफ द पेशेंट इज सेइंग दैट माय सिम्टम्स गेट वर्सेंड बाय वायरल इन्फेक्शन, समटाइम यूआरआई होने के बाद कई बार पेशेंट बोलते हैं कि वायरल इन्फेक्शन हुआ था, थोड़ी सी खांसी आई थी और अभी मेरे को जकड़न होती है, सांस फूलती है. सो इफ दीज आर द ट्रिगर्स ऑफ एस्थमा एंड इफ एट ऑल द पेशेंट सिम्टम्स गेट्स वर्सेंड by the exposure of the cold, exercise, allergen exposure, change in weather, laughter and cardio. So this is all your trigger, and this highly suggests that the patient is having a diagnosis of bronchial asthma. Okay, so these are all the very classical and characteristic patterns, and they are typically seen in the patient with the bronchial asthma. So we all should remember and we all should habit to ask these questions when the patient is coming to us in the OPD. So coming to clinical exam, what we do? Clinical examination obviously start with the general survey. So usually we can see the skin pigmentation, urticarial rashes, and we can see dermatitis that may be seen, that may suggest atopic phenotype. The asthma which is having atopic phenotype, what does it mean? Usually asthma, because of the allergy or atopy, they have other signs like the dermatitis, knuckles will be prominent, there will be urticarial rashes sometime, and signs of dermatitis, skin dermatitis we can see especially. So in this patient we can find these findings on general survey. On systemic examination, respiratory system examination, if we do on auscultation, there may be bilateral adventitious sounds like rhonchi may be heard sometime. So in patient, if we auscultate in the OPD, or we can get some added sounds, especially rhonchi may be heard. But sometime patient may not have any respiratory finding, the patient chest may be absolutely clear in some cases also. All right. And other system, usually other systems are not, there is no any abnormality detected, and other systems are fairly normal. Okay. So this is we finding we get in clinical exam, and if you do an investigation, if you do a basic blood work in a CBC, we can expect some eosinophilia that may be there, or metabolic panel if you do liver and liver, obviously it's a normal limit because it's a does not affect other organ system until unless it has a other association with the other disease also. So here you can see chest X-ray is apparently looking normal, but sometimes there may be hyperventilation lung fields and prominent bronchovascular markings may be seen in some cases, but otherwise chest X-ray is fairly normal in case of bronchial asthma. All right. Spirometry. Spirometry is a very important tool. Okay. So spirometry, we know in our respiratory practice, spirometry is a very important tool to categorize the disease in the obstructive and restrictive part. So we do a spirometry we do a spirometry in the patients having a suspected obstructive airway disease and to confirm variable expiratory airflow limitation, okay, and to document expiratory airflow limitation. So how to confirm variable expiratory flow limitation? For that we do a positive bronchodilatory responsiveness test or reversibility testing that we call. So what does that mean? We do PFT, we look parameter before and after using a bronchodilator. So how does it define? In adults, increase in the FE1 of more than 12%, and mind it, there is an and, mean both should be there, FE1 more than 12% and 200 ml post bronchodilator. If it is improved, that is called positive bronchodilator test. In children, it is increase in the FE1 from the baseline of more than 12% is predicted, that is taken as a positive bronchodilator responsive test. So it means that this airway has a variable expiratory airflow limitation. So it is constricted, but when it is exposed to your bronchodilator, it dilates in response to a bronchodilator and FEV1 improves gradually. All right. So, how to measure? We measure the change 10 to 15 minutes after giving 2 puffs or 200 to 4 microgram of salbutamol, albuterol or equivalent compared with the pre-bronchodilator readings. So, we have to compare pre and post both. So, this is how we do a PFT in our lab, and how to document expiratory airflow limitation, that is FEV1 FV ratio should be reduced. So, FEV1 by FV ratio should be reduced in obstructive airway disease associated with your positive bronchodilator test. It is a suggestive of bronchial asthma. But there is a one important point we have to remember, that in bronchial asthma lung function may be completely normal also sometimes. So, PFT may be normal. Okay. So, in asthma it is not always bronchodilator visibility testing is there, but PFT may be, or spirometry rather to be very specific, can be normal also, that we should keep on mind. So, here is the one example, spirometry showing positive bronchodilator response. Here we can see pre FEV1. If you can see here, FEV1 is 1.15 and a post bronchodilator it is 1.38. Okay. So, if you calculate here, post bronchodilator is FEV1 1.3. The percent change is your post FEV1 minus pre FEV1 divided by pre FEV1 multiplied by 100. So, if you calculate 1.3 minus 1.15 divided by 1.15, it comes around 20%. Here you can see the changes are more than is a 20%, and if you calculate the volume change, that is post FEV1, it should be FEV1 minus pre FEV1, it is 1.38 minus 1.15, 0.23 liter or 230 ml. So, these two things are, one is 20% and more than 200 ml, both are there. So, it is positive bronchodilator. So, this is how we look for, and you look for the ratio here, FEV1 FVC ratio, it is also reduced. This is the predicted value is 83.4 and its value is 53.07. So, it is also reduced, suggesting airflow limitation and positive bronchodilator responsiveness, highly suggestive of bronchial asthma. Fine. So, how to diagnose? We have to simplify a flow chart to diagnose asthma. If the patient is coming to us with respiratory symptoms, they are typical of asthma. We should do a detailed clinical examination and lab work. We should perform a spirometry with reversibility testing, and if spirometry support asthma diagnosis, start treating asthma. So, what are the findings that support asthma diagnosis in spirometry? There are the two findings. One is your document expiratory airflow limitation, means FEV1 FVC ratio reduced, and confirm your variable expiratory airflow limitation, that is positive bronchodilator responsive test. All right. So, this is how to proceed, how to diagnose a case of bronchial asthma in OPD settings. So, this is the most simplified one. So, thanks for watching.